MD Conference Live presents updates from the American College of Cardiology meeting in Orlando, Florida.
The primary outcome of this trial was a composite of stroke, heart attack, blood clot going to the body, which we call a systemic embolism, or vascular death. And this composite outcome was reduced by 11%, a highly statistically significant result. What is of particular importance, however, is that this effect was driven almost entirely by a substantial reduction in strokes of all severity. Strokes were reduced from 3.3% per year down to 2.4% per year. There was also a trend towards reduction in myocardial infarction from 0.9 to 0.7% per year that did not quite achieve statistical significance. However, the number of heart attacks in the study was relatively small, reducing study power. And furthermore, we know from several other types of patients that clopidogrel does reduce heart attacks, suggesting that this result is believable. In this study, most of the strokes were in fact either disabling or severe. A disabling stroke is a stroke that results in the patient not being able to carry on the activities of daily life without assistance. And clopidogrel reduced strokes that were both not so severe and the more severe disabling strokes to almost an equal extent. There was, however, an increase in bleeding. We know that clopidogrel in other situations increases bleeding, and it increases bleeding in these patients. The risk of a major hemorrhage, which was a hemorrhage that required a 2-unit transfusion or more, was increased from 1.3% per year to 2% per year. There was a trend also for an increase in fatal strokes from 0.2% per year to 0.3% per year. One way to consider the risks and benefits of adding clopidogrel to aspirin in these patients is to consider 1,000 patients treated for 3 years. If you did that, you would prevent 28 strokes, 17 of which would be disabling or fatal, and 6 myocardial infarctions, 6 heart attacks, at a cost of 20 major bleeds, 3 of which would be fatal. So in conclusion, it's important to recognize that warfarin, an anticoagulant, and other anticoagulants are the treatment of choice for patients with atrial fibrillation who are at high risk for stroke. However, there are about 40 to 50% of high-risk patients who do not receive warfarin. And for these patients, there's a major unmet medical need, which has now been addressed by the results of the ACTIVATE trial, which show that we can reduce major vascular events primarily by a reduction in stroke with an acceptable increase in major hemorrhage.